Hello and welcome everybody to ICMDA webinars. I'm Dr. Peter Saunders, the Chief Executive of the International Christian Medical and Dental Association, which brings together 84 national associations of Christian doctors and dentists, representing about 60,000 professionals all over the world. And today on ICMDA webinars, we're privileged to have back Rick Allen, the director of MedSend, who's going to be speaking to us on the issue of ensuring medical missionary longevity. So it's a great, as I say, a great honor and privilege, Rick, to have you back again here on ICMDA webinars. The subject of ensuring medical missionary longevity, healthcare missions, which are typically conducted in low resource environments, is both demanding work and exhausting, and the impact on one's life, whether it's professional, relational, or spiritual, crosses real boundaries. And pre-field healthcare missionaries are not typically prepared for the demands they will encounter. And in addition, once they're on the field, they're often not cared for in a way that's appropriate for the challenges they face. Rick heads up MedSend, which is endeavoring to transform the care of healthcare missionaries. And in this webinar, Rick's going to share some of MedSend's model and rollout plans. And I can really commend this to you as a best practice model that I hope others will pick up around the world and use the same principles. So Rick spent 25 years in executive roles within the computer software business, and he was called out of business to be a pastor and to run MedSend, which actually grew out of the CMDA, our US affiliate. MedSend provides grants and scholarships for healthcare professionals to live out their calling abroad. And Rick stepped away from the role as pastor several years ago. He's now the full-time CEO of MedSend, and his passion is to see many come to know the love of Jesus through the delivery of compassionate healthcare. Rick, so good to have you back, and we look forward to hearing what you have to say. Thank you.
Thank you, Peter, and welcome to all those who are joining us. And if you give me just a moment, I will put up a presentation that I plan to share with you throughout this session. And so just as a means of introduction, MedSend has been providing grants to healthcare professionals leaving the United States to serve globally for 30 years. We have provided grants to about 700 individuals. So we have a long history and significant insight into global healthcare missions. We have been concerned for some time about frankly, the health of healthcare missionaries, particularly those leaving from the US to the world, moving into new cultures. And one of the things that we started to do some time ago, let's see if I can get my slides here to cooperate. There we go. So we have been looking at kind of the general condition of healthcare missionaries for some time. And we believe that there are a set of very unique needs with healthcare missionaries that are not always addressed by the sending agencies that help them to live out their calling. And we have this, so this all started really looking at it in some level of detail in 2011, where we actually CMDA conditioned or made this study available. And then we did another one in conjunction with CMDA here in the US in 2015. And we were really looking at the condition of healthcare workers throughout the world. And what we found was that there was significant gaps in both their preparation and on their long-term care for the kinds of conditions that they were facing. So what we did was we stepped into what we're calling the Longevity Project, and we're about to introduce our second iteration, or what we refer to as 2.0. 1.0 was strictly for MedSend grant recipients. And we will go into this 2.0. It began in 2022. We tried several things, and there were 6 components offered at that time. And those things were a pre-field course that was offered by CMDA. We were assigning a coach mentor. So when you received your MedSend grant, you were assigned a coach, and the expectation was that you would reach out to your coach mentor one time a month for the first 24 months of your grant. And this was designed ideally as people were preparing to go on to the field and then their first year once they arrived. And these were individuals who we referred to as MedSend alumni. They're individuals who had been healthcare missionaries and had come back and were now willing to come alongside of those that were heading out. We had an annual checkup. We hired an organization that would provide a stress checkup online, and we categorized the results as red, yellow, green. If it was green, no action was taken. If it was yellow, the individual was invited into conversation with member care specialists. And then if it was red, we would ask them to work with this organization specifically to come up with a strategy or plan for addressing whatever the topic was. We also started to introduce this notion of a MedFresh retreat, where we would bring together mental health professionals, marriage counselors, counselors for children, spiritual counselors, and offer our grant recipients the ability to join us for a week-long retreat. And then ultimately we had this short debrief when an individual would come off the field. We would sit and listen to them so that we could better understand what the needs were of those that were on the field. So Longevity Project 1.0 really helped us to understand what was going on in the field and to get a sense for what the needs were. As we went through this, we were asking for feedback on a continual basis, and you can read on the screen some of the feedback that we received from the initial Med refresh back in 2002. And I think we got it right, if you will. It was appreciated by everyone who had attended, and we think we have a pretty good handle on what the needs are for these individuals. And so we took back, some of the feedback from each one of the areas. And as you might expect, the coach mentor was widely mixed. Some it worked for, some it didn't. The annual checkup was very good, and there were some rescue stories in there where individuals had not really identified that they were under intense stress, and yet this checkup revealed that, and we were able to come alongside of them. And by the way, this is all done in total confidence. We do not, MedSend as an organization does not know any of the details of these conversations. They're a third party that are conducting the checkups, and we don't ask at any point what the conversations were related to, so it's total confidence. We're getting ready to launch 2.0. That will start in July, and there are several unique elements to what we're attempting to do here. First, it's a subscription program, meaning that you will buy into the Longevity Project. It will be relatively small with regards to the amount that's paid to buy into it, but it's think of it like an insurance policy. It's going to be an annual premium. MedSend will heavily subsidize it, and we will step into the care of the individuals through partnering with others. So you'll receive a grant, and then from that grant, you will direct your own care, which is another unique element of this program, is that it's moving from primarily an organization that would reactively support you to a proactive self-directed care model. So you're given a grant, you take that grant and you can apply it to any one of the partners that MedSend has contracted with to provide services. And I'll talk a little bit more about those in a moment. So because it is a novel program, something like this, to our knowledge, has not been tried before, and that is primarily around the self-care model. So we've got a list of 9 various options that you'll be able to take advantage of and buy with your grant. And right now, we just don't know what's going to be popular. There are a number of things that you can choose from, and because this has never been tried before, we're not sure what people will choose. So this is a very controlled rollout. We're going to launch in July 1st, and we're going to do a minimum number of individuals, mostly so we can learn. We don't know what we don't know at this point, but we're going to be measuring it quite closely. We're starting off with 30 units, 30 individuals, couples, and families. And then what we're anticipating is that in the second year, that'll be 23, 24, we should be able to get up to about 60 individuals, couples, and families. And then ideally by year 3, we'll have 100 of those units, if you will, involved in this. So we've got a scaled up rollout, and we're going to have a very short feedback loop, because our intention, particularly in these first years, is to do a lot of learning. We don't know what we don't know at this point. And one of the things that we're expecting because of that is a lot of modifications to the program. We're expecting that it will transform, it will morph as we go ahead and learn from it, as we experience it, as we get the feedback from the participants. So just to give you an idea of the kinds of things that will be available to those who participate in this, you can see the Longevity Project 1.0 on the left-hand side of your screen, and I walk through each of these. The additions to 2.0, when we roll it out in July, is going to be counseling a la carte. And what we mean by that is we have contracted with several organizations that you will be able to use your grant to access them for individual counseling, marriage counseling, couple counseling, family counseling, counseling for children. You will be able to decide how much of your grant you will put against each one of these options, including counseling. Spiritual direction, we have partnered with an organization that has spiritual counselors, and these will be individuals that will essentially help you grow in your spiritual life. Any questions, comments, go deeper, do Bible studies. There'll be several options that you'll be able to take advantage of so that you can continue to grow while you're on the field in your spiritual life. Dispute mediation. We know that one of the challenges of being on the field is disagreements, and we have contracted with an organization who has dispute mediators available, and you will be able to use your grant to bring a dispute mediator in. They can do it online through a platform like Zoom, or they could come in and arrive at your site and be there live. Some of you may have heard about the Christian Global Health in Perspective course. It is a relatively new course. It was developed from the Perspectives course, and this is very highly specialized for global health professionals. And we believe in this course. It is an online course that you will be able to take and apply your grant to it. Another area that is of times a great challenge when you're on the field is your children's education. And we have contracted with counselors and individuals who specialize in developing curriculum and sharing options for how to educate children on the field. So these are individuals who have lived through this in some cases, but understand the various resources that are available either for online learning and or field-based learning. So there are several options that you can step into, and we will help with that should you need an educational counselor. And then finally, an extended debrief. There are organizations that when you come off the field, you're able to go to for a period of time. Should that be a week or 2 weeks? And these are options that'll be available to you. So we're going to add all of the things that are in 1.0 and on the left, and then those items that are on the right as we attempt to launch this. Now, we're going to break it down into two different ways. One is going to be the new missionary pre-field before you go out. These are going to be preparatory in nature. And again, we'll have a coach mentor. We'll do the CMDA pre-field training, the annual checkup, and of course, this perspectives course will be available. So we will provide a grant to individuals before they go on the field in an effort to help prepare them. Then once they are on the field, this extended list here will be available to them after they have been on the field for a period of 18 months. So that's essentially what we're looking at, these two things. Now, at this point, we are requiring that there be a sending agency involved. So this is, we're limiting it right now to just those leaving the US to the world. But we do anticipate over time that we will broaden the scope and make this available on a global basis to any worker out there, any healthcare individual that is in a mission context. So we're launching this with an expectation that there will be a sending agency involved with the individuals that are joining, at least for the next 3 years. And we believe that the support that they provide is highly valuable. And we're doing this in partnership with the sending agencies in order to be able to address the specific needs of healthcare professionals. And in this complementary model that we're desiring, what we're seeing is that you'll be able to choose from a menu. So if your sending agency is very strong in one area, let's say a retreat, you may not go on the MedSend retreat. You could use the grant for counseling or for other items that I've just reviewed. So you'll have options. And what we're anticipating is that we will have the sending agencies making referrals to us to join this program and stepping into it. And we will be identifying those organizations that have a pipeline of new missionaries who are looking to go onto the field. And in that context, we will be offering them these, if you will, a starter grant, the pre-field grant. So this will continue to build over time as we are able to add additional individuals. So in the first 30 invitees, I just want to give you some context for what we're going to be doing here. And we're going to offer these grants to our alumni, people who are still on the field, but are no longer using MedSend's loan repayment model, as well as the people who we are currently paying on their educational loans. So it's our grant recipients and alumni. We already have an established relationship with them. So we're, as I mentioned earlier, we're very much limiting the number of individuals that we're bringing into this. And the timeline is we are about the next couple of weeks going to be sending invitations and registrations. July 1, we anticipate starting these grants and running them for 12 months with just the first 30 invitees. So that's what we're anticipating. So there is a number of uncertainties because we really don't fully understand how people will be using and applying these grants against which services, which of these services will be most popular. And we want to make sure that we have capacity in our partners to be able to deliver the services. Another one, and it's very challenging for us to be fair. We are limited to this number of 30 that we're starting, and we recognize that the need is great out there, and we would really like to be able to scale this up as quickly as we can and try to be fair to all those who initially have a relationship with us, but ultimately on a much broader scale. But as we start off, we have to limit this mostly because we don't know what we don't know. And, as I go into this, I do want to, I kind of want to turn this around and ask some questions of you. Again, we're still in the learning mode. So I would like you to, when we get to the question and answer time, what do you think will be popular? Do you have an opinion as you've been sitting through this presentation? Have you been thinking, I would love to take advantage of that? What do you feel would be most popular for a healthcare professional on the mission field to be able to support them? And also, if there's holes as you're looking at this and you've been listening, are there things that have come to your mind that essentially have said, I'd really like to be able to have something else? Again, in this learning mode, we are looking to try and determine what have we overlooked. So I would love to engage you with questions and enter into an interactive session here. So Peter, if we can start to do that, it would be beneficial to me, and I hope to the audience as well.
Excellent. Thank you. So we're listening to Rick Allen on ensuring medical missionary longevity. And the reason we invited Rick along is because MedSend really have what I believe is a global best practice model for doing this that we can learn from. And so thanks very much for your presentation. Rick, just first, can I just come to you with a question from Milton? You may well know Milton Amayon, who's out in the Philippines doing some amazing work in community development. And he's just asking a nostalgic question about MedSend. Rick, many years ago, before I returned to the Philippines, I had some contact with the Topazians when they were still leading Project MedSend. It was the early phase of the organization. I was wondering where they are now and how many medical missionaries are being supported by Project MedSend this year. How many countries are they in roughly? And he talks about a good experience of it he saw in Malawi. So the Topazians, how many missionaries and how many countries? Can you give us the big picture there?
Yes, the Topazians, both David and Deirdre have joined their Savior in heaven. They're both passed on, and it was a pleasure of mine to know both of them. I had initially gone to church with them. We attended the same church, so I had a long relationship with them prior to MedSend. And so at the peak, we had 180 individuals that we were making loans on, making loan payments for. And we have started a a new program at MedSend called the MedSend National Scholars. And what we're doing is we're coming alongside of individuals in Africa and Asia who are being trained in specialty areas. These are physicians that are being trained in areas like surgery and family practice and other specialties. And we're providing scholarships for them. So we've provided now 90 scholarships and almost 700 grants to help individuals from the US go into the world.
Brilliant, thank you very much. Dave Moore is from the UK, but is served abroad in many capacities. He's asking, do you have any data for how the MedSend recipients have got on over the years? Average length of service, reasons for leaving medical mission, what proportion is still serving overseas long term? And I realized this wasn't part of the presentation, and but just off the cuff, can you give us some ballpark figures or assessments?
I'll say this. We don't. It's very interesting because we have a very large database, as you can imagine, with almost 700 individuals receiving grants. But we never really intended the intention, and we were talking about Dr. DePazian. He never really saw this long-term impact, if you will. So what we're seeing is we would have a relationship while we were paying for the grants, but then we didn't have any long-term relationship, right? So we didn't kind of keep up, if you will. So we're actually in the process of backtracking, and if you're a MedSend alumni and you're seeing this, we'd appreciate hearing from you. We would like to bring you into the community as we try and address those that are going out, particularly now forward. So we've got a good database, but it's not as strong as it could be considering how long we've been doing this.
Now, you mentioned, Rick, in the first program, the 1.0 program, of the 6 elements, the last element was research. And I guess the question is, going forward from here, how are you going to objectively measure the effectiveness of the program? Amigo and Chinwe is also asking, will there be a kind of audit about it's more of the use of the grant, but first of all, the question of objectively assessing the difference that the inputs are making to people on the field, and particularly, I guess, obviously, whether it impacts their longevity. Doesn't mean that more will stay for longer. So how are you going to look at this going forward?
Well, there's a couple of different ways that we're going to look at it. Longevity is one of them. So we have been tracking how long individuals who receive the MedSend grant have been on the field for about the last 8 years. So we've been tracking that rather closely. We've also been interviewing individuals in a debrief model as they've been coming off for the last 4 or 5 years. So we've been accumulating data for those reasons. So we're looking at the reasons and purposes for coming off the field, as well as how long they've been on the field. So the comments of why they're coming off are highly subjective, but we're going to be tracking these things. We're going to be watching with these annual reports just how whether or not it's impacting individuals. And again, we'll use this kind of a red, yellow, green with regards to the condition of their health and their service. So again, because this has been tried before, we don't know what we don't know. And we're going to be doing an awful lot of learning in these early years, trying to determine exactly what we should be measuring. Many of the issues that bring people off the field really they're not controllable. And what we're going to attempt to do is at least provide a level of financial resource and services with the things that we can address.
Yeah. No, it's really helpful, and it's very early days yet. You're just launching the project, of course. Amigo is asking, will there be a kind of audit about how people use the grant? Do you get feedback about how they allocate the grant that they've been given to what, in terms of helping you plan in the future and see what the needs are, but also perhaps for reasons of accountability as well for your grant recipients?
Well, I would say accountability and scalability, right? One of the things that so the answer at the highest level is yes, we will be very closely tracking this, how people apply the grant, because we will need to go out and find service providers, counselors, for instance, individuals who do mediation counseling. So as we see the way that people are using their grant and distributing the resources that we're providing them, we will then look for partners who will be able to deliver those services to the individuals who have the grants. So we're going to be monitoring this very carefully. It's one of the things, the elements that we don't fully understand. We don't understand at all, because until people start applying these in a self-care model, we won't know. And it's at the heart of why we're rolling this out slowly, is we want to make sure that there's enough capacity for people to take advantage of the services. You are likely aware, many of you, that there is a shortage of counselors available on a global scale, particularly those that understand missions, and then even smaller number, those that understand healthcare missions. So what we're trying to do is, over time, we're going to be measuring and monitoring what services are being requested, and then we will start to build relationships with more and more organizations based upon how the distribution of services trends.
Thank you. Can I just say to those listening, just to clarify, if you've got questions for Rick, they need to go into the Q&A icon at the bottom of your screen. So please type them in there. I noticed some people are putting them into chat. Put those questions into Q&A and we'll pick those up. The chat is for the feedback from you about things that you think are going to be most popular in what MedSend's offering, and any omissions, things that aren't on the list that you think should be added. So Rick, I'm going to go to some of these comments now that are coming in from people while we wait for a few more questions to come in. But let me just give you some of the feedback. Nick Woolfield is saying, have you considered including professional development as an area of need? Often we're faced with conditions and treatment options that are challenging to address in our work area, and getting support to improve our personal clinical competence to do this. And Rick, we'll take note of all these things in chat and send them to you afterwards. So please don't worry about having to remember them at this stage. But would you like to respond to that one first, and then we'll move on down?
Well, at this point, we have not taken any of the professional qualifications into mind. It really will be mostly around issues that are experience related as opposed to professional. It's good. I appreciate the question, though, because it is something that these are the kinds of suggestions that I'm hoping to receive from you, where there might be opportunities as we go forward to expand.
We've got lots of people just giving their general appreciation for the talk and saying we wish we had something here like that in Portugal and Burkina Faso and so on. Jenna Weigner is saying, answer to your question, I'd love to take advantage of this someday. I definitely would be interested in the pieces regarding counseling options, missionary kid education. I have at least 2 with special needs. Possibly being a mentee. I do have years of experience on the field, but I always like learning from those who've gone before. Also, I've heard of the medical perspectives class. This sounds really interesting as well. Possible holes covering continuing education, possibly attending conferences or education regarding our specialties or travel fees to get there. Do you want to feedback on that, and then I'll press on?
Well, there's several. Thank you very much. Appreciate that. In particular, we're very interested in children with special needs on the field because we recognize the demands that places on the caregivers, the parents. And one of the things that we will be doing is providing access to the resources, even if we're not in a position where we can provide a grant initially. We will provide access to the counselors, especially those that are specialized in things like coming alongside of parents with children with special needs. So we really are sensitive to that. Thank you. Thank you for the encouragement as well.
Yeah, there's lots of encouragement here and some more feedback. 3 people, Dave Moore from the UK, but ex-Papua New Guinea, Courage from Nigeria, a rheumatologist, Nicola Maxwell, have all mentioned the retreat. I think the retreat will be popular, the most popular, and so on. Nicola also mentions individual counseling and mentoring, and adds as a possible addition peer mentoring or support groups.
Yes.
And Doug Lindbergh, who you know very well from CMDA US, is saying, I'm hoping that coaching is embraced. I think once people experience a session or 2 with a trained coach, they'll see the value and how it can benefit healthcare missionaries. Dave Moore adds, it seems like many people go into medical mission without much in the way of preparation. Walking with people from their student days into medical mission and providing training, helping them make good choices about ways to prepare well. So would you like to feedback on any of that, Rick?
Well, I would agree. I mean, we have 50 mission sending agency partners, and they love their missionaries, and they're from the very largest here in the US to rather small organizations. And even the ones who do it very well, they treat all of their people the same, meaning in preparation and care options. And what we're trying to do is to really augment them and the services that they provide in the area of healthcare missions. It tends to represent about 10% of the missionary force. And because of its size, it doesn't get a lot of very specific attention, but the level of stress and the things that are encountered by healthcare missionaries do require specialized care. And that's really what we're trying to do here, is we're trying to come alongside of both the sending agency partners and the individual missionaries and provide a level of care that is very specific to healthcare professionals and the challenges that they face when they're on the field.
Now, you mentioned that a lot of missionary sending organizations are already doing some of this stuff, although it's a bit sporadic and patchwork, and part of the reason for shifting to this new model of self-directed care is that you're giving people the opportunity to fill in the gaps that are there from their own missionary sending organization. Are there any other organizations like MedSend which are doing the same kind of thing but for all cross-cultural missionaries rather than just healthcare? Or is this model really the first that you know of like this in the US?
It's the first that I know of, and I think the newness of it, if you will, is really around self-care. Right? This is a self-care model where you identify, you're given the resources for you to identify what your needs are, and then to pull down from a menu of services that you can access. So there's a shift here that's occurring with regards to member care, if you will, from being strictly provided by the sending agency to the individual now being able to select those services that they want at any given point. And what we're anticipating, this is going to be an annual grant. It is going to be a use it or lose it model. So we want you to use it in the year that you're given the grant. So you'll have an opportunity to pull down all of the various choices and options that we're giving to you within that year. So that's the shift, the innovation that's occurring here is moving care from primarily the auspice of the sending agency to the individual.
So Rick, just on the subject of the grants, and not necessarily asking you to divulge exactly how big the grants are, but are the grants, is it a standard amount given to everybody, or is it means tested, would be my first question. And secondly, can you give us an idea of within a year, how many of these services a person would be able to afford with the grant that is supplied? Would it be just taking one element, or could it be a smorgasbord of several different things?
Well, so what we're going to do is there'll be one amount for a single, there'll be another amount for a couple, and then a tiered amount for families, right? Yeah. So if there's children involved, because we do want to provide assets, financial assets, for children as well. So this is truly family ones, you know, for those that have children. So it's going to be a scaled amount, and your pay-in price, if you will, is going to be scaled as well. So it'll be lower for single and then scale up. It will be large enough to take advantage of multiple services. Something like a retreat is very expensive. So, you know, if you decide to use the retreat, you're going to consume the majority of it. But if you decide to take perspectives that year, that's not a whole lot of money. And you know, you would have plenty of additional funds to take counseling. There will be enough funds in generally that you should be able to, in any given year, have a significant number of hours of counseling available to you. We're working on kind of the proposed selection, right? We walk down and say, okay, if people select these things, this is how much it would cost if they select. So we're looking at all the various options and trying to consider that. We think we've got it. We think we've got a tiered amount of these grants that you'll be able to apply, that you will be able to take advantage of a number of these services.
Thank you. So Nick Cook. Nick is a British doctor, served in West Africa in family medicine, ophthalmology, and so on. He's saying there is a massive disparity between what a first world doctor thinks that he or she can do in a resource poor setting and what the receiving medical facility thinks is realistically possible. On the other hand, the only way to understand these expectations is a preliminary visit to the work before committing to the work. Should a preliminary visit with two-way feedback be made compulsory, or at least some kind of short-term experience, I think? What's your thoughts on that?
Well, I absolutely agree that is essential, because a large part of what we're trying to do with the services that we're offering pre-field is to help set expectations. Part of the challenge is that the expectation of the individual prior to going and the reality when they get there are misaligned. And we're trying to help with that alignment. We haven't built in the financial resources for a visit ahead of time, although I would say that after reviewing almost 700 applications, the vast majority, and I would say 90% of the individuals have at some point gone over and participated either in the exact location where they're looking to go long-term or in a similar location. So those resources have generally already been available. So what we're trying to do is address the areas where these resources have not been available, right? That's a very good observation, though, and I entirely agree with you about its importance.
Yeah, a bit more feedback now on areas. Amigo and Shimway, I think coaching will be the most popular. Sherry Falkenheimer, who you'll know well from MEI, been
Yep,
on
sure.
webinars before as a speaker. I think a retreat will be most popular. I'd add participating in CMDA's continuing medical and dental education conference, as it is a combined retreat CME member care counselling program with an excellent children's program. This is the program that CMDA runs once a year, either in Greece or in Southeast Asia. Getting away for rest and encouragement in a nice setting has been said to be something that kept some workers on the field. And then Doug Lindberg he's really asking a question more. He says, has there been consideration of financial planning assistance, kids' education, retirement, public student loan forgiveness, tax planning, etc., as an addition to the suite of the longevity services, financial planning?
That's a tremendous idea. And I would say no, that we haven't incorporated that in it, but it is a very good idea. Our larger sending agency partners generally have individuals on staff who help with that. But the mid-sized to smaller agencies do not. And that's a tremendous idea. Thanks for that, Doug.
Here's another great idea from Alison Bosson, saying, I think that providing a network to enable medical missionaries to connect together in peer support groups would be beneficial, as well as the individual counselling and courses and retreats. And as you've already intimated, you've got a huge database of alumni as well. What about peer support, Rick, as part of the program?
Yeah. Thank you. That will be the next thing that we add. Thank you very much for the affirmation of that. So we want to become very intentional about creating a network where we can connect people and then take birds of a feather, people who have common interests, and allow them to group together as well. We're anticipating that we will bring individuals in who can address particular topics, much like Peter has done here for that community and around these special interests. So we're actually working on a model that would reflect that. And I really appreciate the encouragement because we think it will be of value, but you're never really sure.
Dave Moore is adding, another hole could be the area of spiritual formation or ongoing discipleship. You've mentioned spiritual direction input, which will cover part of that, but knowing Christ and growing as a Christian are foundational. We kind of assume that's going to happen anyway, but of course it doesn't always.
No, appreciate that comment, because we think it's actually critical to the long-term success, and the demands typically placed on healthcare missionaries is so intense that it's very easy to step away from a regular quiet time, from regular Bible study, and we want to encourage that participation by having a spiritual coach, if you will, come alongside of you and help you and firm you up. Also, the demands can lead to a weakening of one's faith. And we want to be able to shore that up. We want to provide you with resources that if you're questioning your faith, and every one of us do at some point in our life, if you're struggling with your faith, that you have a place to turn to, that you have resources to be able to access individuals that will come alongside of you and help reinforce that.
Yeah. And you mentioned coaching. You're talking about mentoring now. Shari Falkenheimer has come back to say there would be a benefit as well from having a mentor with whom they connect well at their actual service location, as opposed to elsewhere or past experience, to help orient them, adjust to the differences in equipment, services available, or lack of equipment and services available, encouragement, support. And she mentions the Loma Linda, which is the university in California, specializing in healthcare mission, has a good program for helping those planning on medical missions. It might be worth touching base with them to see anything. Another one,
Before you
Johnson
move
saying,
on, Sherry,
that-
if you could send me a contact name or do an introduction. I'm not aware of that program at Loma Linda. I know a lot of what they're doing. I'm not aware of that program, and I would like to be. Thank you.
okay, there's a long comment there that we'll send through to you. Doug Lindbergh has given the link for pre-field orientation from the Louisville conference last year, which will include as well to you and to participants.
And we're very excited. We're very excited about that. I mean, the fact that this offering will be available, and Doug recently sent out an email letting people know that anyone who is within in the U.S. who is within 5 years of heading out onto the mission field is welcome to join into this preparatory class, which is an outstanding. And now it's going to be readily available as a pre-conference offering for the Louisville conference. So we're very excited about that opportunity to come alongside of individuals on a much larger scale.
So that's the big conference in Louisville, Kentucky, every November, which will be happening this year. Shari's raising the question, Rick, of MedSend envy. Is there a danger of, you know, you have a mission set up and there's one person who's on the MedSend program and no one else is, and they're getting such wonderful care and support, and the others are very jealous about it. Bit like the child sponsorship thing, isn't it? You know, that one child in a village. What's your concerns about that? I guess you'd say, well, we want to make it available, allowing resources to everybody eventually.
Yeah, I mean, we'll move. First, we recognize it, and that was the comment that I made earlier about fairness. You can move it into envy. I can see that, but we have to start somewhere. We have to start relatively small, but you can be assured that we will move as fast as we can because we recognize the need. And you can see from the studies that we've recognized this need for a number of years. We're finally at a place where we can put it into action, and we will grow it just as quickly as we can. And it's not, this is not a financial resource issue, it's a human resource issue. We want to make sure that if we give you a grant and we tell you, here's the 10 services that you can take advantage of, that we have partners who have capacity to take you on with those services. So the scaling issue really is making sure that we've got the resources available for everybody who gets a grant. And again, our commitment here, and Dr. Jim Ritchie is heading this up here at MedSend. Our commitment is to move as fast as we possibly can. If we can find, you know, veins of resources, if we see the way that people are applying the grants, we'll move as quickly as we can to try and build partnerships and expand the number of grants that we can offer.
Yeah, no, absolutely. And one can see the wisdom of not wanting to dilute the product, but to really help a small number well and get it all sorted out and then scale it as resources allow. So I think there's going to be a bit of MedSend envy inevitably, but I think it should be for the good of everybody ultimately. Rita Nichols is saying, should ICMDA partner with this project at some point? Well, that's a question for the future maybe, but the point she's making is her country, she says, has almost zero of the care you mentioned. The doctor and the family are almost on their own on the field, covering all the needs and expenses. And I can see certainly in the future that once this really takes off and starts to deliver, it's going to be something that others will want to be learning from and adapting. And that perhaps brings us to this is probably the last question we've got time for, is relating to the long-term future of medical missionary work. And you've described very much a model still very valid of cross-cultural missionaries crossing from resource-rich places into resource-poor places with all the challenges that they face and wanting to support them. But given that the pattern is moving from mission about from everywhere to everywhere, and also in terms of developing strong Indigenous churches and missions of people to serve in their own resource-poor contexts, is this part of the whole idea of medical missionaries making themselves superfluous by training local people? Is this part of the mission of MedSend that you see for the future in terms of the way it's going to develop?
Well, that's a big question, but I would say generally we're attempting to do two things at the same time, if you will. For the Western missionary who's being sent out from the U.S., we're hoping to provide a level of services to them which extends their longevity. At the same time, we're providing scholarships to individuals in Christ-centered residency programs throughout Africa and Asia. So we're trying to build the number of national, and at this point it's limited to physicians, the number of physicians that have been well trained in a Christ-centered context. So we're trying to do both of these things. The need is so significant, so large, that I don't think we could in any context meet it with both of these things: Western missionaries going, or our national brothers and sisters being trained up well. This is going to take, the need is so great that it's going to take decades for this to happen. So we're going to try and do both of those things at the same time. Shore up the Western missionary, give them what they need to be sustainable, and to come alongside of our national brothers and sisters and help them with advanced training. Ultimately, we see a 3.0 or a 4.0 here with the Longevity Project, where we will come alongside of our national brothers and sisters and offer this. So the Longevity Project. So initially, it'll be focused on the Western missionary, but ultimately we see this being available in a much larger context for the needs of our national brothers and sisters.
Thank you so much, Rick. And that's, I'm afraid, all we've got time for today. We've been listening to Rick Allen from MedSend on ensuring medical missionary longevity, about the best practice model that they are launching. So it just remains for me to say thanks again, Rick, for your time, experience, and interaction. We look forward to seeing you again very soon on ICMDA webinars. God bless you.